All right. Good afternoon, everyone, and welcome to the January 11th edition of It's Worth a Shot. And today, we hope to go over commonly asked vaccine questions, a little Q&A with our very own Dr. K. And we'll also be discussing some flu testing protocols. And I will just mention we're having a little bit of IT difficulty this afternoon. So bear with us as we try to get our guest speakers on the line here.
This is Lucy. I just joined.
Hi, Lucy. Thank you so much for being here.
Yeah, sorry. I tried like 10 minutes ago when it said nobody was in the meeting. So I don't know what I did wrong.
Oh, no problem. We'll just go through a few housekeeping slides. We have audience members joining us from the waiting room, and then we'll kick it off. So glad you could hop on. Thanks for letting me know you're here.
Yeah.
All right, next slide, please. As always, many thanks for everyone, or to everyone, for being here today, and all our partners and attendees. And we sure appreciate everything that you guys do on a day-to-day basis and taking the time out of your busy day to join us. And we hope that we're bringing you relevant information on a weekly basis. Next slide, please. A few housekeeping items as always. Again, any topic ideas or clinician ideas, feel free to add those in chat. We'll continue to meet same time, same place every Wednesday through the end of the year. And I also have a few resources that we'll toss your way today that were recently introduced this week. First polling question. Polling question for this week. Where do you currently receive your COVID-19 vaccine from? Do you get it from your primary pharmacy? Are you using a mobile pharmacy? Maybe County Health is still working out well for you, state, and maybe you are an approved vaccine provider site. Other, feel free to enter that in chat. All right, looks like pretty close to well, still a few responses coming in. I'll give you guys a moment here. Where do you currently receive your COVID-19 vaccine from? Currently the polling question. All right, we can go ahead and end that poll. Thank you guys. It looks like most folks are still using the pharmacy, and there's also a decent number that have become approved vaccine provider sites. So great news. All right. Share results. All right, thanks as always for participating in those polling questions, you guys. Next slide, please. So as always, we just like to touch base on where we're at in the world with our weekly influenza snapshot. And we will say that although seasonal influenza activity remains rather high, we are continuing to see a decline, a very welcomed decline in most areas. And I will say also that they're continuing to watch closely susceptibility to the influenza antivirals that we currently have available. And we are seeing that there is a good match for those antivirals, and also a very good match for the annual flu vaccine this year. And a reminder, annual flu vaccine is the best way to protect against flu, and vaccination helps to prevent infection and serious illness. Next slide, please. So as we take a little peek at the weekly COVID-19 snapshot, you know, last week, some of you that joined us may recall that we saw a little bit of a downward trend and we held our breath. And now this week we see a little bit of an upward trend. So unfortunately, we are still seeing high transmission throughout the country. Interestingly enough, when you look at a map and you look at community levels are looking low on the eastern part of the United States, or excuse me, high on the eastern part of the United States and lower on the western, but those darn transmission levels remain high throughout the country. And folks are continuing to monitor the US and the global trends. You've probably seen some local reporting as they look at wastewater monitoring and COVID-19 viral levels within the wastewater. Still continuing to encourage staying up to date with your vaccinations, and we will drop a few resources in the chat for you that were released earlier in the week. I'll just highlight a CMS resource that was released on Monday, specifically an audio cast 3-part series that aligns with some very nice consolidated resources for anyone that needs some additional assistance as far as vaccinations. All right, next slide, please. Dr. K, were you able to join us? And if Dr. K is not on yet, then Lucy, we will jump to your presentation first. Mary, if you don't mind. So we'll give Dr. K a few moments to get on and do an audio check. Again, thank you guys for being patient as we've had some technical difficulties this afternoon. So without further ado, we are so pleased to welcome and have Lucy Magnuson on as our guest speaker today. She is with the Wyoming Department of Health and is a surveillance epidemiologist for Wyoming. And she is going to be sharing with us flu testing protocols. Lucy, thanks so much for being a guest for us today.
Yes, thank you for having me. So as you said, I'm one of the surveillance epidemiologists, and I do healthcare associated infections. We also have a vaccine preventable epidemiologist named Kaylin. I sent her an invite. I'm not sure if she joined, but she's a really good resource as well for questions. Flu kind of falls a little bit under both of us, so I just wanted to introduce her.
I'm here if you need me.
Great, thanks for joining. Great, next slide. So I just wanted to do a brief flu overview. I think we are all pretty familiar with influenza, but I wanted to go over testing protocols during this, especially during flu season, because I think it is good to not just test for COVID-19, and because respiratory illnesses, it's hard to tell without proper testing if it's flu, COVID, RSV, or something different. So I just wanted to kind of point out the importance of trying to understand what we're dealing with. And then also it's a good reminder for staff and patients and residents, despite our best efforts with testing and infection control measures, I think the best way to reduce the spread of flu and serious complications is by getting vaccinated. Right, next slide. So a very brief overview of flu testing methods. There are molecular assays, and then there are antigen detection tests. And for the molecular tests, they do have a rapid molecular test available. They also have RT-PCR and other molecular tests, but some of those have a longer turnaround time. They have to be sent up to the lab, where the antigen detection test is a very quick test, although sometimes it's not as accurate and needs to be followed up with a molecular test. And the Infectious Disease Society of America, they do recommend an RT-PCR test, if possible, for inpatient, and then for outpatient, if you're going to do a rapid test, they do recommend the rapid molecular test when possible. All right, next slide. So this is just a kind of guide for patients who have signs and symptoms of influenza. This could be, you know, either at a clinic or going to your physician's office or hospital. So essentially, if you don't have symptoms of flu, they probably won't test you, but the only exception for that is long-term care facilities. If there's an outbreak, sometimes they will test, they'll do active surveillance and test people in close contact despite symptoms, but otherwise, you know, they probably won't test for influenza if you don't have any symptoms. And I think where they really want to get a good picture, if you test positive for flu, instead of treating it empirically, is if you're hospitalized or if it's going to affect infection control or clinical management. All right, next slide. So there are multiplex testing options, and these are really useful when COVID-19 and influenza are co-circulating. So for inpatient or patients that are hospitalized, they really want to test for both COVID-19 and influenza. So you can either, if you have access to the multiplex molecular test, that is one way to do that if your laboratory or facility offers that. You can also just do two separate tests. You can do a COVID-19 test and flu test. If you do the COVID-19 antigen test, they recommend following up with a PCR test. And that would also require two specimens if you're going to test separately. But if you do have access to the multiplex test, that is a great way to help determine if you have which one you have, if either. And then for outpatient, that's still an option. They definitely want to test for COVID-19, and if that, and then whether you test for influenza on top of that, kind of again depends on if it's going to affect infection control decisions. So, because if you test positive for one, it doesn't exclude the other. So they do recommend testing for both if possible. If not possible, you can also, if you're negative for COVID-19 or influenza still suspected, you can prescribe empiric antiviral treatment and also diagnose it as flu based on clinical judgment. All right, next slide. So the testing recommendations for long-term care facilities is essentially the same for acute care inpatient, but the CDC does have a lot of, they have a separate page for long-term care facilities because especially with outbreaks and reducing spread, there are some differences. So I just kind of put it on its own slide because they do have a whole resource for long-term care facilities, but you would want to place any suspected for either COVID-19 or flu in transmission-based precautions. And then you're going to want to test any resident with symptoms for either. And again, like I said, because that a co-infection can occur, a positive influenza test does not exclude infection and vice versa. So you really want to try and test for both. And then you're going to make placement decisions, follow infection control practices, and prescribe antiviral treatments based on test results and clinical diagnosis. I don't know if that's my computer making that weird noise. Hopefully not. All right, next slide. So testing methods are, I think there's always the ideal testing, but there's a lot of determinations, like depending on your laboratory capability, what testing facility has, clinical laboratory improvement amendment, so CLIA waived reported care use, timeliness of results, you know, sensitivity, affordability, these are all factors. So on my computer. So that is a really good resource, that CDC overview of influenza testing. There's a lot of information there, which is great. So I think knowing the recommendations and then kind of tailoring it to your facility, it would be very useful. All right, next slide. I also wanted to briefly go over suspected outbreaks in long-term care facilities. I do get a lot of questions, and this is, suspected influenza outbreak in long-term care facilities. I do get a lot of questions about this because I think with COVID, sometimes we don't always cover flu guidance the same way. So an influenza outbreak in a long-term care facility is defined as 2 cases of laboratory confirmed influenza within 72 hours of each other in residence on the same unit. And then you're going to want to implement outbreak control measures as soon as possible. You also, if you're waiting for test results, or if there's just one respiratory case, you're going to want to start active surveillance for additional cases, and that should be implemented as soon as possible because it can spread so quickly. It's not something that has to be reported to the health department or considered an outbreak after one case, but you are going to want to start thinking about testing other residents that have symptoms or that were in close contact. All right, next slide. And you're going to want to conduct daily surveillance until at least 1 week after the last laboratory confirmed influenza case was identified. So after that, it can be considered over. And then you're going to want to test residents for influenza with a molecular assay for any ill persons who are affected on the affected unit. You don't have to just limit the testing to people in the same unit, but that's probably going to be priority. And you can also expand testing to unaffected units depending on the size of the outbreak. And then if you're waiting for test results or you're unsure if somebody is flu positive, if they're being treated empirically and they still develop acute respiratory illness symptoms, then you might want to expand testing. And then the local health department and state department should be notified of every suspected or confirmed influenza outbreak. So not every flu case has to be reported to us, although you're welcome to report them to us. It's the more information, the better. But an outbreak has to be reported, and that could so I think that's it for the slide. And the return to work guidelines aren't nearly as specific as COVID-19. So if you do have a fever, they want you to be fever-free for at least 24 hours without any fever-reducing medication. But not everyone will have a fever, and not every case is as severe. So they want you, because you're most contagious within that first 3 days, they do recommend staying home at least 4 to 5 days if your symptoms are improving. So just try to stay home if you're sick, give it that 4 to 5 day range to so you're not as contagious or not contagious anymore, and just make sure your symptoms are improving and you no longer have a fever. All right, next slide. Any questions?
Hey, Lucy, there is a good question in the chat from Maria. In Hawaii, she thought it's 3 cases that meet the reporting requirements. Is it state specific? For
so
how many?
I was looking at the CDC website, so it wasn't for Wyoming specifically, but these are positive cases. That's just based on the CDC. Do you know, Kaylin?
I don't believe it's state specific. Here in Wyoming, we do go by what the CDC recommendations, which is 2 cases. But I'm not entirely sure what would be the case for Hawaii.
Oh, and it looks like Kelly was able to join us today. Thanks. Kelly O'Leary's on the line too. And she just confirmed Hawaii is 2 cases for flu. It's 3 cases for COVID. Thanks, Kelly, for chiming in. We appreciate that. Good question. Good question. And I feel like that's where we've been so COVID focused that this is so helpful to to refresh our memories on a lot of this other stuff too. Kelly, did you have anything you wanted to add? Maria thought that COVID was actually still just one case.
Yeah, so Kelly, we're following CDC definition for flu, which is the 2, and then we follow the CORA definitions for COVID. And what else was I going to add? Oh, and then yes, you want to make sure CMS defines outbreak for COVID as 1 case in a staff or resident. So there is going to be differing definition of outbreak for COVID. I don't think there's differences for flu, but CMS is going to have their definition, but Department of Health for when you report an outbreak will be different.
Thanks, Kelly. And again, if there's any confusion still around that, or if anyone needs any further assistance, let us know. Good questions, you guys. Thanks, Maria, for asking that. Any other questions? All right. Dr. K, were you able to join us?
I think so. Can you hear me?
We can. We can.
My computer decided I was a security risk and it shut my microphone off.
We'll go figure.
Yeah.
Well, thank you.
Might be right. I don't know.
Well, thank you for joining us. I guess we'll welcome Dr. K. He's going to be visiting with us with some commonly asked vaccine questions. So you have the floor, Dr. K. Thank you.
Thank you. So one of the first questions that's quite common is, how do I encourage my staff to get vaccinated when others get vaccinated and they still become ill? And the simple truth is that no vaccine is 100%. You can get the influenza vaccine, and some years you still get influenza. But the absolute truth is that if you get vaccinated, you may still get COVID, but your chance of having a serious infection, winding up in the hospital, winding up on oxygen, winding up on a ventilator is infinitesimal compared to people who weren't vaccinated. And also your risk of having long COVID symptoms, which are no joke. The more we read about it and learn about it, the more grim it is. Your chance of getting long COVID, if you got the vaccine, are markedly reduced. So yes, you might still get ill, but the point is you won't get very ill. If you don't get the vaccine, when you get ill, it may be significant, it may be serious. So the best option is still to go ahead and get the vaccine. Will getting the COVID-19 vaccine give me COVID-19? No, absolutely not. All vaccines are just a means of tricking your immune system into thinking it has already seen a disease. And there are different ways to do that. You can do that with a live bacteria or a live virus that won't make you sick, but it looks like the wild virus that will. You can do that with a killed virus or a killed bacteria or a toxin that's deactivated. In the case of the best COVID vaccines we have right now, the Pfizer and the Moderna, it makes your body manufacture a very small amount of part of the virus, not the whole virus, just a little part, just that little knobby thing that sticks out. And so your immune system sees that and it can respond to that then when it sees the real whole deal if you encounter the flu virus. So it is the doorknob, not the entire door, and it can't give you COVID and it can't make you sick. Can I get the flu vaccine and the COVID vaccine at the same time? If you think about it, all day long, our bodies are encountering viruses, bacteria, fungi. It's in the air, it's on our skin, it's on surfaces. And so our bodies are always responding to multiple germ invasions, and our immune system handles all that just fine. So getting the flu vaccine and the COVID-19 vaccine at the same time, even in the same arm, is perfectly fine. Your body can handle it. It was developed to handle it, and it does it all the time anyway. How do I tell if it is COVID-19 or the flu? Well, you could go to a palm reader, I suppose, or somebody who has some other questionable credential. But the truth is, it can be difficult. Both can cause upper respiratory symptoms like headaches, sore throat, nasal drainage, cough. And the best way to tell which it is to get tested. And as has been mentioned before today, sometimes you have to test for both because you certainly can have both together, especially at the height of flu season. Now, if your symptoms include loss of smell or loss of taste, it's quite a bit more likely that it's COVID because that's not common with other respiratory viruses. And if you have a lot of GI symptoms, nausea, vomiting, diarrhea, it's more likely to be COVID. But really, you need to be tested to know for sure. There are medications now for both COVID and for influenza, so it's worthwhile to get tested because you might be able to treat it and save yourself getting sicker than you need to. Should I get the COVID-19 vaccine if I have already had COVID? Absolutely. As I said, no vaccine is perfect. And what we have learned is that those people that have the best antibody response are people who were infected with COVID and got over it and then also got vaccinated. So just because you had COVID doesn't mean that you should not get the vaccine. And what we are seeing now, especially with this new strain, which is highly transmissible, is that people are getting infected a second and a third and even a fourth time. And if you get vaccinated, as I said in the beginning, that may help prevent you from getting significantly ill or getting long COVID symptoms. So if you had it, good for you, get the vaccine and you'll be doubly protected. I think there's another slide with questions. So how do I encourage residents to receive this vaccine if it is still under emergency authorization use and not fully approved? That is true. However, what is also true is that it was tested in the same testing procedure that every other vaccine is subjected to, and it was found to be safe and effective. And at this point, the vaccine's been out there for a couple of years, and worldwide, literally hundreds of millions of people have been vaccinated, and bad outcomes are exceedingly few. This is a very clean vaccine. Now, when you look on the internet, you're going to find tons and tons of misinformation, and a lot of sites are going to be telling you that people are dropping over dead from this vaccine. Those are all just frank lies. I don't really know what people's motivation is for that, but the people who do this for a living have studied it thoroughly. As I said, hundreds of millions of people have been vaccinated. The number of significant problems with the vaccine are just infinitesimally small, like 5 or 6 per million doses given. So it's as clean as we can make a vaccine, and they're very effective. How effective are the bivalent boosters? Well, there's some debate about that too, and that's recently in the news. The thing we can say for certain is that the bivalent boosters are the best vaccine we have right now. They're probably in the 80 to 85% range in terms of protective effect. It looks now like, much like influenza, we're probably going to need an annual booster to continue to cope with COVID. But we do that with other infections too, and influenza is a good example of that. So these are very good vaccines. They're very effective. They're very safe. What are the side effects of the bivalent boosters? The common side effects, very much the same as with the initial vaccine. Soreness at the site, headache, muscle aches, fatigue, just feeling kind of crummy for 24 to 48 hours. Very, very similar. So why should I get the vaccine if I can still get COVID? Well, that's essentially a different way to word what we've already talked about. You're much less likely to be ill. You're much less likely to die. Probably much less likely to give it to another loved one or friend, and much less chance of having long COVID. So I highly recommend getting vaccinated. You know, you can be an example to your staff and make sure that you're fully vaccinated and let people know that. Try and counter some of this disinformation with good solid facts, and just realize that nobody has any ulterior motive for doing this. We're trying to keep everybody safe, and by doing that, trying to keep our life as normal as possible. And really, the only way we're going to do that is through vaccination and you know, people staying home when they're sick and that sort of thing. I believe that's it, unless there are other questions people have. Sort of been beating the same drum for a couple of years here now, but that's where we are.
Thanks, Dr. K. Anyone have any questions? No, we're rounding out the last week in the 6-week VAX campaign. We have been sending out resources as we've continued to identify them. So anyone has any questions or anything, feel free to ask. All right. Well, thank you, Dr. K. We sure appreciate you joining us today. And again,
You're very
if you guys
welcome. If people do have questions, they can contact me at Mountain Pacific as well. So I'm happy to answer, and if I don't know the answer, I speak the language and I can find an answer for you.
Well, we sure appreciate it as always. And I'm just looking through the chat before we let everyone go. It looks like Kelly was able to clarify outbreak reporting, and she's dropped some links into the chat box to help clear up any confusion there may have been about reporting requirements as far as number of cases. Again, that's in the chat.
Yeah, I just want to add too, sorry, Sissy, just to make sure you check with your health department, because as my colleagues are showing me, we do have a nuance where it's 3 cases. So just double check your health department and make sure you're following the outbreak reporting requirements. Because even though CDC has one definition, health department might have a different. Thanks.
Thanks, Kelly. And Dr. K, it does look like there's a question in the chat regarding vaccination. Jennifer comments that ACIP no longer recommends aspiration when administering vaccines. However, we have seen some nurses that are very concerned about not aspirating before providing the COVID-19 vaccine. Do you have any comments on that topic?
Yeah, I think, you know, these are sub-Q injections or intramuscular. They're not really particularly deep injections, and the chance of, you know, hitting a big vessel that would be worrisome is quite small. And if you were to inject the vaccine into a you know, say a significantly sized vein, as far as the studies are showing us, there's really no problem with that. Your immune system, of course, circulates through the blood system, and you'll still get protection. So it's really not necessary. And I'm not sure exactly. I think maybe they were somewhat concerned that when you do that, there's a chance that you will have a slightly smaller dose, but it's not necessary, and so we really don't need to do it. I understand that you know, when you're trained to do things a certain way, sometimes it's hard to break old habits, but it's really not necessary. And you certainly don't need to be worried about not aspirating.
Thanks, Dr. K. That's what I had been understanding as well, is that there might have been just a minimal concern about dose reduction with that practice, but also the general picture, like you mentioned, was really those recommended sites for immunizations don't have major blood vessels. So it wouldn't really serve a purpose to continue that practice. Thank you. Any other questions, you guys? Great questions.
This is Lori, just tagging on to the great info that Dr. K shared. I think that if we educate staff who are providing vaccines, that instead of using the aspiration technique, if they're worried about hitting a small vessel, is to look at the syringe, because, you know, that potential, if you had happened to hit something, of having blood in the bottom of the syringe show up would be visible. So that might be a re-education technique instead of aspiration, to just encourage a visual cue, visual check of the syringe itself at the bottom where the needle is for any signs of blood before they're administering the vaccine.
Lori?
Sure.
Great questions, great comments, you guys. Well, we have gone over time this week. As always, this will be recorded. We will send it out with next week's reminder, the slideshows and the recording that is. And very special thanks to Lucy and Dr. K for being our guests today. And thanks to our audience for your patience while we worked through some IT issues. And same time, same place next week. Be well, everyone.
Thank you.
Thank you.